So at the end of yesterday and the beginning of today, we've kind of emphasized how much data collection is used in discrete trial training, and we talked about some ways to interpret the data. And that kind of segues into our next topic, which is really the last one we're going to talk about in the workshop, and that is generally what constitutes evidence-based practices for kids with autism, and where does discrete trials fit within that. Okay, so I wanted to spend some time talking about that. And in the autism world, those of you who've spent any time at all working with these kids know that there are all sorts of treatments out there of different kinds. And so I want to start with sort of a plea for using evidence-based practices based on data collection. And then talk about what kinds of things are tip-offs that something is or is not evidence-based, and then talk about some particular treatment models, and talk about why they're classified the way they are, and then circle back to ABA and discrete trials and talk about the evidence there. So we alluded to some of this yesterday when we were talking about ultimate goals, so beyond the individual teaching plan, where are we headed with this? But we want to talk more specifically about what we actually know in terms of outcomes and that sort of thing. And then I want to bring it back, since this is really intended to be a practical workshop, to talk about what that means for you as you go out and work with these kids. Okay? So in autism, and this is true of a lot of behavior disorders generally, you could say much the same about ADHD or many other things. But in autism, we have a somewhat checkered history of trying to serve these kids. And it goes back for a long time, and it arguably is getting worse rather than better. So in the 1940s through the 1960s, just to go way back to the beginning, autism was actually first formally identified in the psychiatric literature in 1943. And almost immediately, people started essentially blaming parents for causing autism. And in particular, psychoanalysts such as Bruno Bettelheim argued that children with autism had quote-unquote refrigerator mothers who were very cold and off-putting to their kids, and sort of drove their kids into living into their own worlds, to retreat kind of into a shell. And what they would do is they would try to provide unconditional love and attention to the kids with autism. And it turned out, by the 60s, certainly, and by the 70s, it became clear that the parents of kids with autism were just as loving as parents of any other kids. The only difference is that they tended to be under higher levels of stress, which certainly makes sense. And that the things that psychoanalysts did actually tended to make kids worse. So if a child is doing something inappropriate and you take that as an opportunity to show how much you love them and care for them, you'll actually encourage them to keep doing that behavior. So if they're like hitting themselves and you say, oh, I love you, they'll hit themselves harder. And there are actually studies demonstrating that effect, and you could pretty quickly see the child's behavior actually escalate when you did those kinds of things. That was really kind of a dominant perspective for about 20 years. And in the 70s, psychoanalysis started to fade away some, but then there came to be some interventions that I've grouped under the general heading of bonding therapies. They were based on the idea, again, that for whatever reason, the child had failed to form an attachment to the parent, okay? And so these similarly involved providing sort of unconditional love and attention to the kids. And there are some of these that are still around. There's one called Sunrise or Options that still exists. Every so often you'll hear about another one called gentle teaching. Now, an interesting thing about all of these is that for all the difficulties that kids with autism have with social communication, they're actually pretty good at attachment. So they are definitely attached to caregivers. So some of you already work with kids with autism. And so maybe I'll just put the question to you. Do you see them forming attachments to people who are familiar to them? Like that they clearly recognize and are happy to see people that they work with regularly? Yes, so yeah. So actually they're good at that. And so that's actually not an appropriate thing, you know, of all the things that you could be treating, that's not one of them. So again, these were kind of a bust in terms of appropriate treatment approaches.
And Martha Welsh still fits in that too, right?
Yes. Yeah, so the holding therapy. And holding therapy is still around. I think you see it more with families of kids who are adopted or who've had some sort of trauma. So what would happen with holding therapy, which still happens with these kids a lot, is that the parent would be directed to hold the child until the child stopped trying to get away. And there's some variations called rebirthing therapies where you kind of make a womb with blankets and things, and you kind of force the child in the womb until you think they're ready to come out. Unfortunately, as you might expect, that actually carries some risk. That there have been kids who've been asphyxiated and have actually died in these sessions. You know, not only off base, but potentially risky as well. Okay. And then moving into the 80s, there was a lot of excitement starting in 1982 with a drug called fenfluramine. And there was just a report with 3 kids showing that one of them seemed to benefit, and that set off a big rush to prescribe fenfluramine. And as you may know, fenfluramine was part of a dietary package called fen-phen that was actually taken off the market in the 1990s because it caused heart damage or caused a risk of heart damage. So that was another one. You know, so subsequent studies didn't bear this out. The medication itself turned out to have pretty significant risks. And so that was, you know, fortunately faded away. An interesting one in the 1990s, which has made a comeback, is called facilitated communication, and I alluded to that yesterday. So we were talking about the importance of not prompting inadvertently because the kids can become very sensitive to that, and they'll pick up on your prompt rather than what you're trying to teach them. And I mentioned that facilitated communication was an entire treatment built on inadvertent prompts. So the kids were, the thought was you could guide their hands to type out messages. And what happened, actually, the way people found out what was going on was that kids started to type out these messages about having been abused, often sexually abused. And so then it became critical in the courts to determine, you know, was this something that the child was saying, or was it something that was, you know, the facilitator was imposing on them. And so what they would do to test this in court context would be they'd set up a situation where either basically the child and the facilitator would either hear different instructions or see different responses, and then you could tell, you know, whether the responses reflected what the facilitator was seeing and hearing or reflected what the child was seeing and hearing. And it turned out in essentially all cases that it was the facilitator, what the facilitator was seeing and hearing, controlled what was actually communicated. Okay. So again, this wasn't just like a harmless, you know, miscommunication, so to speak, that people were actually, families were actually facing accusations of sexual abuse, had kids pulled out of the home, taken into foster care, and that sort of thing. So this was a big deal in the early and mid-1990s, and then it sort of went away for a while. Then it actually came back in 2005. There was a documentary called Autism is a World, and that won an Academy Award about facilitated communication. And then now facilitated communication is on the upswing again. And there was two other movies at least on facilitated communication. One was called Autism the Musical. Have you seen that? And then there's one that just came out this year called Jabbers and Talkers. The chief proponent of facilitated communication in this country, a person named Doug Bicklin, is now the dean of the School of Education at Syracuse University. So that's upstate New York's contribution to, to some of this, unfortunately. What seems to motivate this is often a justifiable concern in the disabilities world and with many other clinical populations, that the main people you hear from about the condition are the therapists and the researchers and so on. You don't actually hear from the kids themselves. And people talk about the importance of hearing these voices of marginalized people, and that's an important thing that researchers ought to be trying to do rather than just speaking for them. But in this case, in fact, they are speaking for them, but just attributing their own communication to the kids. So that, this has turned out to be really quite damaging and quite difficult to make go away. Another one in the 1990s was a hormone called secretin. And what happened there was that there was a show on NBC Dateline in 1998 showing a child who seemed to have made remarkable improvements with secretin injections. And there was also a case report, and again it was 3 kids, one of whom seemed to show benefits. So that led to a whole rush of interest in secretin. And in fact, when I first moved to Rochester, many of the kids that I was working with were involved in this huge secretin study where they had to go in for weekly injections, and there would be data collected on all sorts of things. Every little thing they did, we were collecting data on. We actually had to collect data on their stools. So if you think collecting data on discrete trials is onerous, imagine yourself doing that. We had to collect data on, so yeah, we had to follow them in and check out what happened and describe it. So, so science marches on, and then all kinds of behavioral data. One positive development actually at that time was that the National Institutes of Health put out a call saying, this is all of a sudden a big deal. Can we get some research studies going on this? And so a lot of people rushed in and did studies. And there ended up being 15 studies that are called randomized clinical trials, where kids were randomly assigned to get either secretin or injections of essentially sugar water, placebo intervention. And those 15 studies involved somewhere on the order of 780 kids. And they found absolutely no benefits for secretin. And so the popularity of secretin has waned some, but it's still out there. Some providers still offer that as an intervention. You know, it's not as risky as some of the other things we talked about, but it's not risk-free either. There have been some fairly significant side effects reported with secretin. Okay. So, lest we think, you know, things have improved over time, this actually also started in 1998, but it continued into the 2000s. There was a study in a journal called The Lancet that came out in 1998 in which it was alleged that children with autism had something wrong with their intestinal system, GI system, such that peptides would leak out of their stomachs and into their bloodstreams and then into their heads and cause brain damage. And it was said that this leaky gut, as it was called, originated in vaccinations. That's something about the measles, mumps, rubella vaccination caused this leaky gut, and that had downstream effects resulting in autism. And that was a study of 11 kids, and you know, again, reporting physiological changes. It didn't actually report that these changes, they couldn't really link the changes to vaccines in the report, and they couldn't link any of that with autism. So they just had 11 kids who already had autism, and they argued that they had leaky guts that arose from the vaccines, even though they didn't test that, and that the vaccines led to the leaky gut, which led to the autism. And that led to a big vaccine scare that continues to this day. So I haven't checked lately to see if I could get an update on these figures. But measles, which is part of the MMR vaccine, had been targeted. The World Health Organization had the goal, maybe an optimistic goal, of eliminating measles from the earth, the way smallpox is gone, by 2010, last year. And what happened was that the immunization rates dropped dramatically, especially in the United Kingdom, where the study was originally published, but also to some extent in the United States and other English-speaking countries. And so then there started to be outbreaks of measles and other things that were covered by vaccines. So in the case of measles, they had been down to under 100 cases in Europe at the turn of the millennium, and then they were up to over 12,000 cases by 2006, 2007, and 13 deaths attributed to measles. And then there were also outbreaks in parts of the United States for measles, and also for pertussis, which is covered by the DTaP vaccine, diphtheria, tetanus, and pertussis. Pertussis is whooping cough. So there have been outbreaks of pertussis as well. You know, most kids who get that get over it, but some kids are really quite severely affected. So, so if anything, you know, the stakes have increased over time. So, you know, in the 40s, it was certainly bad to blame parents, but as far as we know, nobody died of anything that anybody said. But that's no longer true. People have died as a result of studies or reports purporting to explain autism. Now, in this particular case, this has been quite a saga, and you may be familiar with some of it. Do any of you know who Andy Wakefield is? Okay. So he's subsequently, he was from the UK, but he's actually taken up residence in this great state, Florida. And so we still have Doug Bicklin, but he came under investigation in the mid-2000s for the original research study that was reported in 1998. And the Lancet, which had published this study, published a retraction from most of the co-authors. And then there started to be investigations both by journalists and by the journal itself, as well as the hospital where he worked. So he left, came here. But the investigations continued. And last year he actually lost his license to practice in the United Kingdom. And in the last few months, additional things have come out. So it turns out this study, which originally involved 11 kids, was done at a kindergarten birthday party. So fun party, right? So come to the party, get a shot. You know, have your biopsy of your GI tract. There were some families who were suing vaccine manufacturers, alleging that there had been some damage from the vaccines, and they had this birthday party, and Wakefield was being paid by the families as part of their lawsuit, and so he came to the birthday party without going through the usual procedures of getting review of the study protocol and you know, approval of assurance that the procedures were safe. He just showed up at the birthday party with a bunch of needles and took the samples and made, as far as we can tell, this is still not proven, but the allegation is that he made somewhere on the order of $700,000 for his participation in the court case. And the most recent finding, a journalist was able to go back and look at the medical records of those 11 kids, compare them against what was in the report, and there didn't seem to be much connection between what was in the records and what was in the report. So it looks like, again, not proven yet, but the allegation is that the data were just made up. So this huge vaccine scare that really has had significant impact on public health seems to have originated with something that was made up for hire, you know, not real at all. Okay. So a very serious allegation. As the MMR theory about vaccines kind of fell apart, another theory about vaccines came into place, which was that metal in the vaccines was contributing to autism. And it used to be until about 10 years ago that some vaccines, not including the MMR, but some others, had a mercury-based preservative in them called thimerosal. So, you know, if you think about, you know, what might be involved in making and distributing vaccines, you know, if you want to have a vaccine and stabilize it so you can bring it to third world countries or, you know, large developing countries like India or whatever, you need some sort of preservative, or else you need to have refrigerator cars going with the vaccine. So they had thimerosal. Many of the vaccines had thimerosal in them. And currently, there are a couple that still sometimes do. The flu vaccine, the annual flu vaccine in some forms still has thimerosal in it. So as this relates to autism, people started to make the argument that maybe the thimerosal was causing the autism. And sort of independently of that, but in a way that ended up fueling the fire, the Institute of Medicine and the American Academy of Pediatrics decided that maybe it wasn't really necessary to use thimerosal anyway, so they could just take thimerosal out. But this raised the concern that there was some sort of cover-up, that you know, they were taking out the thimerosal so they didn't do any more damage and covering up the damage that they did do. And so along with this whole idea then that autism was somehow related to metal exposure, there came the idea that you could treat autism by using what are called chelating agents. And chelating agents are medications that you inject somehow into the body, and they bind with metals, and then the intent is to bind with the metals so that they are then excreted from the body. So it sometimes happens that chelation is used in conventional medicine. For example, if a child has a really high level of exposure to lead, which still happens sometimes, so old houses may still have lead paint and little kids get into stuff. So in situations like that, you still get a few cases of pretty high lead exposure, and maybe more worrisomely in inner cities, in many places, there's still low levels of lead exposures that many kids encounter, and it might still be enough to have some effects. So in any case, the idea was that for autism, maybe you could treat it by doing chelation to take out the mercury or whatever heavy metal was thought to be involved. And so this started to be something that was done, again, on a sort of fly-by-night private way, and ended up becoming very popular and still is pretty popular. However, there was a case in Pittsburgh where a 5-year-old boy had a chelation, a 5-year-old boy with autism had a chelation injection and died about half an hour later in the office. It's a healthy 5-year-old boy. And there have been a couple of other cases of kind of off-label use of chelating agents that have also resulted in deaths, not for kids with autism, but for other people. So again, the general point here is that the stakes are high to get this right. It isn't just the case that there are treatments that don't make any sense or don't work. There are treatments that have caused an awful lot of suffering and even death for kids with autism. So there's still some things that are pretty popular. Chelation is out there, diets are popular, and there's another one called hyperbaric oxygen therapy, which I'll describe a little bit. So there's still a number of different interventions out there. So these are examples of things that go wrong when people are not relying on evidence to develop treatments. And on the other hand, we also know that from research there are some effective interventions, or behavioral interventions primarily, and then at least in some cases, and you can argue how many cases, certainly not all or even most, but in a few cases we have evidence that medication may be beneficial to the kids for certain behaviors. And I'll talk a little bit about that as well. But before, again, going into specifics, I just want to give you a general idea of what would be considered a scientific evidence-based treatment and what might be a pseudoscientific treatment. So when people talk about evidence-based practice, they generally mean an approach that involves, above all, looking at the scientific literature and seeing what works in that literature, and then taking that and seeing how that fits, with the child's needs and the family's needs, what makes sense in that situation. And I think we've emphasized this when we talked about discrete trial training. We've just described it in a different way, that there's a general procedure of discrete trial training, and it's very much individualized based on the child's response to the intervention, where the child is at overall developmentally, and that sort of thing. So we have a general approach, and then we take into account our assessment of what the child needs, and develop a treatment plan based on that. And that's the essence of evidence-based practice. Okay. And in the autism world, there are kind of two methods that people use to test interventions. One are what are called single case designs, and I'll come back to what that is. Another is what are called, well, I guess this is on single case designs, so let me talk about that. So single case designs are kind of like what you started to do and what we looked at yesterday, where we're looking at an individual child and we're collecting data on that child's performance, and we're essentially using the child as his or her own control. So like on some of the graphs we looked at yesterday, there was a baseline before the child started the treatment, and then there was a treatment. Okay. For research purposes, what people will sometimes do is replicate that. So they might have a baseline, then they have the intervention, then they go back to baseline, and then they go to treatment again. Okay. And if you can make the show that the behavior changes when you introduce the treatment, goes back down to where it was when you go back to baseline, and then increases again when you bring back the treatment, that's a sign that the treatment is really associated with an effect on the behavior. Okay? Does that make sense? Another way that people do this is that they would have different baselines for different behaviors or for different kids. So we might, let's say we're testing out a discrete trial program, and we might want to test it on a few different kids. We might start them all on baseline, and then we start one of them in the discrete trial program while the others are still in the baseline, no treatment condition. Then once we see how the first child is doing in intervention, then we'll stop the baseline for the second child and introduce the intervention for that child, and then same with the third child, and so on from there. So if you then see that there's not a lot of change in behavior during the baseline, but every time you introduce the treatment, you get an effect, that's a pretty good sign that something is going on with the intervention. So that's one kind of approach that people use. Another important aspect of that is that before you as a provider would see it, it would undergo what's called peer review. It would be submitted to a journal, and reviewers would take a look at the data and see whether they agree with the interpretations that the authors were making, whether it looked like the study actually supported those conclusions, and that sort of thing. Okay? So another feature of single case designs is that basically you're following each subject over time, each child over time, and repeatedly collecting data on that child's performance. So continuous data collection. So here's an example of a single case study that was published. And in this particular study, the child Mark was eating, the problem was feeding, which we mentioned was an issue for many of the kids. And in this particular case, the child would basically stuff food in his mouth to the point that there was a risk of choking. And so what they did was it was kind of an interesting little twist. They had this pager that they had Mark wear, and the pager would cue him when he could take his next bite. So it just, there would be a pager, go, and then he could take his bite, and then he'd have to wait, and then the pager would go off again, and he could take his next bite, and so on. Okay? So, and then there's a line with circles, which is the time that he spent sort of eating appropriately rather than stuffing his mouth. And then the triangles are the number of overall bites. Okay? So what you can see here is the first condition, the page prompter is absent, so that's a baseline condition. And then they introduce the pager prompter, and what happens? Yeah, eats more slowly. Okay, so the more appropriate eating, those circles. Then they take it away, and what happens? It goes back to stuffing his face. And then they bring the pager back, and what happens? He's done. Okay. So, so this is just one kid, so we don't know, whether the pager would work for everybody. I've been tempted to use it in my household, but I don't know. But certainly for Mark, we can say with some confidence that this procedure works. And if you have a number of replications with different kids of this kind of effect, then you can start to say, this may count as an evidence-based treatment. Okay. So one demonstration with one subject probably isn't enough, but replications with a number of different kids would start to make you say this qualifies. All right? So the other approach that people use in the autism world and generally to evaluate treatments are what are called group designs. And ideally, at least theoretically, what you would do is you get a group of people who are potential subjects or participants for this study, and then randomly, like as if flipping a coin or using a random numbers table or something, you assign one group of those participants to get the treatment and the other not to get the treatment. Okay. So by assigning randomly, you end up, you hope, with groups that are pretty much the same on whatever it is you're trying to treat. So it's a study of kids with autism who are learning to communicate. You would hope that their levels of autism and levels of communication and whatever might affect their response to treatment would even out if you randomize enough kids to each of those two groups. Okay? Or to give another example, we're doing a study now where we're looking at kids who have autism along with ADHD behaviors, and we're randomly assigning to groups, and we are anticipating that by the time we're done, we're going to have we should have pretty equal levels of ADHD and similar behaviors across groups, because we're trying to pick who goes in which group in a completely random way, and it should balance out over time. Okay, and then in medication studies, you can actually go a step further. You can't really do this in behavioral studies, but you can, in medication studies, you can actually have like a pill that contains the medicine, and then another pill that looks exactly the same but doesn't have the medicine, would be called a placebo. And you could also set it up so that there's a pharmacy, like the University of Rochester has a research pharmacy that dispenses the medication. So we don't know, are they getting the medication or the placebo? Family doesn't know. Nobody knows except the pharmacist. So our evaluators don't know, our clinicians don't know, investigators don't know. So that's called a double-blind placebo-controlled study. Now, with behavioral intervention, you can't really do that. The clinicians have to know that they're doing behavioral treatment. The observers, who are looking at the effects, probably have to know that the kids are getting behavioral treatment if they're watching the treatment. So you may not be able to do that, but at least in medication studies, you can often go to that length. Okay. So here's an example of what data might look like in that kind of study. This was a study published on a medication called risperidone or risperidol, and that is sometimes given to kids with autism who also display behaviors like aggression and self-injury and that sort of thing. And they're being rated on this scale called an irritability scale. So irritability was the name given to the scale, and it measures a sort of combination of tantrums and aggression and things like that. So want to emphasize up front, lots of kids with autism are quite easyggoing and cooperative and in a good mood and not irritable. So this is not, not all kids with autism, not even most kids with autism would qualify for this study. But there are a fair number of kids who unfortunately do have those behaviors. And this was a study of whether this medication would be helpful. So since we're talking about irritability, less is better, right? And there are two groups here that, and you may have difficulty reading the lines, but the top line is placebo, and the bottom one is the risperidone. So what's happening in this graph?
They're less irritable. Okay. When taking risperidone.
Yes. So at least on this rating scale, and some people would question whether this is the best measure of irritability. It's basically having somebody sit down and rate the scale as opposed to looking at it directly. But at least on this rating scale, you see a big reduction in irritability on the risperidone, and you really don't on the placebo. Okay, so this is an example. So this was done without anybody being told whether they were on medication or placebo, without the raters knowing what they were on, and it involved 125 kids, and you get this effect. Okay, so those are examples of what we would consider to be evidence-based treatments, and then there are some other things that we, as we have discussed, would not consider to be evidence-based treatments, and often there are some tip-offs that that's what you're seeing. So we've seen for whether it's single case studies or group designs, the argument that this is an evidence-based treatment is based on presenting some data. Like here are some controlled data, where we, systematically introduced and took away an intervention or randomly assigned people to groups, and here are our numbers. Okay. Whereas for non-evidence-based treatments, what you often see is people just saying, "Oh, this changed my life," or this is this was a miraculous thing. So it's really like a personal report instead of an actual study showing a controlled design and an effect on behavior. What you'll also see often too is that, as in many of the examples I went through, the interventions are really based on a new theory of what autism is. So these are all new theories, like autism is caused by refrigerator mothers, autism is caused by mercury, autism is caused by a leaky gut. And when we were talking about autism yesterday, we didn't talk about any of those things. We talked about it being a disorder of social communication. When people looked at things that might have something to do with the causes, we've talked about, people have talked about genetics, like it seems to run in families, and that it affects brain development. So that's completely different from saying it's caused by refrigerator mothers or leaky guts or whatever. So if you see something where they're saying it's not caused by, genetics or brain development, but instead it's caused by something else, that's a sign that this is a kind of out there treatment. Another thing is, if the evidence comes in and people are still doing it, that's a sign that they're really not responding to the data. So the fact that people are still doing facilitated communication, even though there are now hundreds of cases showing that, is the facilitator actually communicating, that's a problem. The intervention hasn't changed one bit, even though, it's been shown not to work, hundreds of times over. And so these are kind of different ways of saying the same thing. So, if they keep citing these personal stories, but not, the actual evidence showing that it doesn't work, then that's a sign that, you're just on the wrong track here. So, okay. So here are a couple of examples, and without labeling them as scientific or not, what do you think of these? So the first one is from an organization called Defeat Autism Now. So this summary generally follows the DAN philosophy, which involves trying to treat the underlying causes of the symptoms of autism based on with an emphasis on nutritional interventions. Many of the day-on treatments have been found by listening to parents and physicians. So would that, how does that sound to you? That sounds anecdotal. So that, in fact, is a bad sign that they're probably purveying pseudoscientific treatments. So again, obviously there's nothing wrong with listening to parents and physicians, right? You got to do that. So I'm not saying don't listen to people, but that that's again part of individualizing the treatment plan, but that's not how you identify effective treatments in the first place. Okay. So here's the second one. This is from an organization called Autism Research International. So most of the treatments listed on the following pages were evaluated as part of the Autism Research Interview survey of over 23,000 parents on their opinion of the effectiveness of various treatments for. So there's actually a saying, and I forget where it comes from, that the plural of anecdote is not evidence. So, so here we have 23,000 anecdotes, but we still don't have a control study. Okay, and so. It does. Again, that's a bad sign. So I'll come back to this in a little bit more detail, but just to give in broad outline, we think of autism as a disorder involving brain development, but the fact is that most treatments, the primary treatments, are behavioral and educational. And I'll come back and talk specifically about discrete trials after we go through some other things. But basically, approaches that are based on applied behavior analysis, including discrete trials, are the ones that have been studied the most extensively. And then there is some evidence, like that study I presented to you, that for a few kids with autism, medications can also be helpful. So again, I'd be cautious about this because, first of all, most of the kids don't even have these problems that you might consider medications for. Number two, often the evidence is based on these kind of rating scales, which we worry about. And number three, even when there's evidence for the medications, there's often also evidence for behavioral interventions. So it doesn't mean, even if you can show that the medication works, you still might not want to do it. Reasons why you may not want to do it is that there could be side effects that could be fairly significant. So, for example, risperidone causes quite a bit of weight gain in many kids, and that can lead to all sorts of health problems, as you know. So, but that said, there are studies suggesting that it can be effective. So, again, this is for what was called irritability. There is evidence, at least in the short term, for medications like risperidone. There's also some evidence for medications for hyperactive behaviors, although here the evidence is, and the effects seem to be a good deal smaller. And even less certain, there have also been studies on medications for repetitive behaviors, like the spinning of the ball that we saw yesterday, and also for depression and anxiety, which are things that many kids with autism might have, but not most. And there's some evidence for this, but it's still, the jury is still out on in a lot of cases for these medications. Okay. So again, I want to come back to ABA and discrete trials in more detail. But before doing that, I'll just talk about some other things. So those are basically it. So there's a gazillion interventions for kids with autism, but that slide basically showed everything that you could consider at this point to be evidence-based. Okay, so I'll have more to say about it, but it fits on one slide. Okay. Now beyond that, there are other interventions that are kind of I would say they kind of fall in between being clearly evidence-based and being out-and-out pseudoscientific. And so I've described them here as plausible interventions, meaning that they make some sense, but they haven't really been tested very carefully at this point. basically these are under-researched, but they do actually target things associated with autism, and they do use teaching methods that make some sense. You know, they're similar to things that might work in other situations. So recall that we said that bonding therapies, as an example, treat attachment, which is actually something that kids are pretty good at. These interventions that I'm calling plausible, you know, actually target social communication behaviors, which, you know, are definitely relevant for focus and intervention. And they'll use teaching methods that resemble, to some extent, what we might do in ABA, for example. One program, this is really kind of a set of procedures. It's called Project Teach, and it originated in North Carolina. Have any of you encountered Teach programs? Okay, so it's pretty widely disseminated. Basically, it emphasizes using a lot of visual supports, which we talked about yesterday. So, you know, there are some differences in how they're done in Teach versus ABA, but, you know, it's in the ballpark, at least, of things that we might do. And they focus on really providing structure, which we talked about as being important, at least from an ABA standpoint, because the kids are kind of often at a loss, you know, if they're left to their own devices. So they'll set up like workstations for the kids with a lot of visual cues. And they have a number of interventions of that sort. So again, very little evidence on it, but you know, at least it's in the ballpark. Then there are another set of models that are called developmental models, and one of them is called floor time, or DIR. Does that ring a bell to anybody? Okay. So again, it actually focuses on social communication, which is relevant, and it involves trying to follow a child's lead as the child plays, and trying to encourage communication in those situations. So, you know, again, that's not an outlandish idea, you know, that could work, but there's not actual evidence on it. So these are the kind of treatments where people are saying, well, this might be worth studying because it, you know, makes some sense, but that haven't been studied yet. So in the case of Teach, there is a big study underway, and so maybe we'll find out soon. That study is actually comparing Teach to an ABA model called LEAP, and I think it's in its third year. So, and it's a 5-year study, so 2 or 3 years. You know, stay tuned. We'll see see how it comes out. At the DIR, I'll just quickly say there's the only thing that is really available to this point. The developers at DIR went through their own charts and said, gee, it sure looked like our kids did well, which is not very compelling. But there are actually some studies underway of that as well. There was actually one little study comparing DIR and ABA, discrete trials, and ABA won that one. But again, that was one kid. So there are also these other developmental models, and it's actually something that the people who describe themselves as developmental therapists are having to deal with now. There are all these developmental models, and they're having to kind of stake out their territory and identify, you know, what's the same and what's different about them. And so there's been a good deal of controversy about that, which us behavior analysts just kind of sit back and watch. But I happen to have a couple from clips from the Denver model on my computer. It was suggested that I show them just to contrast with the discrete trials that we've been talking about. So let me do that. And this is Sally Rogers, who's the developer of what's called the Denver model.
Ready for both? Here it comes. Whee! Whee! Good job, Logan. Here comes Bob. Bob. Here. is ball. 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 Okay.
Good time was had by some. Anyway, see some of you smiling. So what do you notice in comparison to discrete trials? What are similarities, differences?
It's not as a structure, I guess. She's on the floor, crawling around him, rather
Yes.
than being sitting.
Yes. So I think that's a clear difference. So, we've got the, sitting them down in the chair and often with a table and this, the data collection, and they're on the floor. And so it is a more play kind of situation. What else? Yes?
Well, it seemed to me with just watching the discrete trial training that it was clear that there was an objective and a goal for whichever session you showed. But here I couldn't quite figure out what the objective was.
Actually, to be honest, I wasn't sure either, so what she was trying to get at. But has something to do with ball, I think. But you're right, kidding aside, in discrete trials, there's no question what the target behavior is or what the goal is. And part of it, in fairness, is that if you're trying to play with the child and let the child initiate some play, what happens in the session is determined by the child to a greater extent, so it's harder to say, I'm working on this today.
Well, you could still say I'm working on child-initiated play.
Right.
So.
Yeah. So.
Like code that or something.
Yeah. So there might be a more general category that you could make. But it's still, the flip side of that is it risks becoming unclear, where you're going with this. But the child has more say in what happens. So. Okay, other comments? Yes?
How old is this child? 2. 2?
Yeah. Yes.
Can you clarify for me the goal of this type of therapy? Is it just increased social reciprocity?
Yeah.
Or?
So the argument, I think that's a good question. So what people argue, and this is again at the level of argument rather than data, is that, the core difficulty in autism is social communication. And then you put the kids in discrete trials, and that's not really a social communication situation, so how could they ever learn social communication in that setting? And so the idea here is to set up a more typical social setting, which for a 2-year-old involves play, right? And to work on teaching language in that setting. But then the flip side is kind of what we've implied here. So in the discrete trials, we know exactly what we're trying to get, and we, can track that pretty well, whether we actually are getting it. Whereas there's a risk that we, get kind of lost in whatever it is we're trying to get in the developmental session. The other thing that discrete trial folks argue is that, so here you have a 2-year-old who has no language, and we've already talked about how, by and large, these kids have parents who do all the great things that parents do, and, the parents have tried to play with him and get him to communicate that way, and he has no language, so he's been unsuccessful in that situation. We're going to need to do something different. Then going back to the developmental side, they would be arguing, well, if we could just be more systematic about this, maybe we could get them learning, and we'd be working directly in a social communication situation. So that's the issue here. So as it stands now, there are a number of studies underway on these kinds of approaches, and there have been a few successful reports. So Sally Rogers' group had a report that came out about a year ago indicating some success in accelerating kids' development with this model. And there have been studies, focusing more specifically on communication or on teaching parents to do these kinds of interventions that are also reporting some success. So one of the things we're actually doing now, we're in our group, we're doing a comparative study of discrete trials and one of the developmental models to see how we actually stack up going head to head. So we shall see. That's in its second year, so you'll have to stay tuned for another 3 years or a little longer for us to pull together the results to see how that came out. Okay. All right, but good comments. So again, these are things that people think are worth studying because they do focus on things that make sense, unlike some of the other stuff we were talking about. Then there are other treatments that I think would be more controversial, and so we'll go through those briefly. So these are ones that have these kind of anecdotal reports of effectiveness, but they don't really make a lot of sense. But some of them are pretty common. One general category are sensory motor therapies, and there's a whole bunch here, but perhaps the best known of these is sensory integration therapy. Does that ring a bell for anybody? Okay. And then there are also some medical treatments, which I'll talk about briefly. So in sensory integration, the idea is to provide these kind of sensory activities that are designed to stimulate the senses in kids with autism. And they're usually focused on a sense of motion. So you see these swings here and the trampoline, or on the sense of touch. So you see that in the top left. Okay, and the idea here is that there's some sort of sensory processing or motor planning. So either they have trouble taking in sensory information, or they have trouble taking that information and producing a response. And that's the idea there. So one intervention we mentioned already, facilitated communication, is refuted, I would say. But all the others haven't really been studied. And I should say that in general, there is some evidence that kids with autism have some issues with sensory processing and motor planning, but they don't really have anything to do with swinging or touching. So for example, I mentioned the study yesterday where the kids do well when they see either gestures or they hear voices, hear talking, I should say, that they actually may do better than other kids. But when you try to put them together, that's where they have trouble. So that's an example of a sensory issue that's been demonstrated in these kids. But that really has nothing to do with swinging them from the ceiling, right? So, but it just doesn't. And there is some evidence that the kids have motor delays, but again, that has nothing to do with, dipping their fingers in finger paint or something like that. So, there's some issues there that need to be attended to, probably better than they have been as far as developing treatments. But these kinds of treatments don't seem to have much to do with that. Okay. So about sensory integration, this has been the conclusion that was drawn about 10 years ago, and there haven't been any studies since, really. In terms of the complementary and alternative medicine, this gets at the diets and those sorts of things. So the secretin and non-vaccination, as we discussed, have been refuted. The chelation is way too dangerous to think about any further. And really all the others are under-researched. To talk about diets in particular, the most common diet involves taking out gluten, which is a protein in wheat products, and casein, which is a protein found in dairy products. So the kids go on a diet where they're not allowed to have wheat or dairy products, which is often a hardship for them because their favorite foods might be, they're often they like complex carbohydrates, for example, and then they can't eat those things. And there's some risk we've found at the University of Rochester that some of the kids who go on these diets end up having nutritional deficiencies. So if you take out dairy products in particular, you risk problems with protein intake, vitamin D, and calcium, as you might expect. And if you replace them, what people will often do is find substitutes like soy products, which personally I have a tough time with, like soy milk, and I can't do it. But so that is another issue in terms of the diet. So there are things that many adults would struggle to accept as an alternative, and we're trying to get these kids who are already kind of picky to accept those. But in any case, they don't really have the same nutritional makeup, and so they don't entirely work as substitutes. And actually, some soy products, for example, are fortified with magnesium, and we've found that some kids actually overdose. Not having terrible effects, but actually going beyond what's considered a safe level of magnesium in their diets. And so there's some risk involved in the diet. The one decent published study on the diet was actually done in Florida by Elder and colleagues. I think it was at the University of Florida. And what they did was they had 12 kids, and they put them all on the diet first, and then switched them back to a regular diet, or they started them on a regular diet and then put them on the gluten-free, casein-free diet for about 6 weeks each. And they had a whole bunch of measures, and to make a long story short, nothing. Up at the University of Rochester, we have a study where we proceeded a little bit differently. We've presented the findings, but they're still not published yet. But basically, what we did, again, as Elder did, we put everybody on the diet, and then rather than switching them on and off the diet, we kept them on the diet for 18 weeks for the study. And during that time, once a week, we'd come with snacks, and the snacks contained gluten and casein, or only one, or the other, or neither. And we had like bakers and all kinds of people helping us come up with things that each child would actually accept, and that looked identical with or without the gluten and casein. And we'd go out and give them to the kids. So different kids had different things in their snacks, and then we'd give them the snack, and then if there was any left over, we'd bring it back and weigh it. We'd have to seal it, so the liquid didn't evaporate. And we looked at 3 sets of behaviors, or 3 sets of outcomes: behavior change, like autism behavior changes, social communication, more general attention and hyperactivity behaviors, and then sort of biobehavioral things like feeding patterns and sleep, like did they sleep better, those sorts of things. Again, to make a long story short, we found nothing. So there was no change that we could see. And when there was even a hint of a change, it was actually that they did a little better when they had the gluten and casein. So, that was probably, if you have enough measures, something will come out. So that was probably in that category of a fluke, but that's basically what we found. Okay. So there are a whole bunch of other interventions like this. Again, all of them are under-researched. One thing I just wanted to highlight briefly that's become popular in the last couple of years is called hyperbaric oxygen therapy. Maybe around here, more people go deep sea diving than in Rochester, but deep sea divers will actually go into these chambers when they come back up to kind of adjust their oxygen levels. Okay, so it has that's why these chambers are on the market. And what they do is they give pressurized oxygen. Now, as you may know, pressurized oxygen is flammable, so there's a risk that it'll literally blow up. So, you know, again, it's not, it looks spiffy, but there's some risk associated. And the idea here is there's some evidence actually that kids with autism may have signs of inflammation in their bodies, and that might be associated with what are called free radicals, which are isotopes of oxygen that might be circulating in their bodies. And the intent is to give pressurized oxygen to deal with these free radicals. Okay? But again, this is all pretty tenuous. We don't really know if that's actually true, and if so, does it have anything to do with autism? An incident, I think it was in Miami, it was definitely in Florida, where a child and grandmother flew in from Italy to get hyperbaric oxygen treatment, and they both went in the chamber together. The chamber blew up, and they were really quite seriously injured from that, and I'm actually not sure how they're doing. I mean, we're talking, you know, severe burns, you know, on most of the body and things like that. And again, no real evidence for that. Okay, so bottom line so far, the things that we could consider evidence-based are ABA interventions and at least in some cases medications. Some other things that may be worth studying, like TEACH and these developmental approaches, and then a whole lot of stuff that doesn't make a lot of sense. All right, so now I wanted to talk a little bit about ABA interventions. And I think one thing I want to do for starters is not exempt us from scrutiny. This is actually used, it's a part of the advertising materials for an ABA program, but it kind of states what people like and dislike about ABA, encapsulates that in science. So Save the World with Behavior Analysis. And so, you know, then the question is, well, how are we doing with that, you know? As it applies to the research on ABA, there is general agreement, as I've already mentioned, that there's more research on ABA and discrete trial kinds of procedures than on anything else. But there's also this concern that people are exaggerating how good the research is and how big the effects are, and you know, kind of overstating their ability to save the world from things in general and autism in particular. So we'll take a somewhat closer look at this, and then, as I said, we'll bring this back to some practical applications. So the question is really, what do we know? And there have been a lot of task forces and things like that to try to get some agreement on, you know, what's actually reasonably well established and what is not. But I think a consensus has kind of emerged that you can look at different kinds of evidence and draw some different conclusions about that. And in particular, one thing that people have done is started to view these single case studies like that pager study that we talked about as kind of a first step and often the only step that you need to take in order to validate a treatment. So what those studies do is they show clearly a short-term effect. So like there was no question in that study that the pager was helping with the feeding. And then if you get enough of them and there are groups that have figured out how much they think is enough, like the American Psychological Association says 9 studies involving at least 20 kids from at least 6 different sites. If you have that many, then you can say that something is an evidence-based treatment. So some things qualify on that basis, but then there's also times where people have said, well, you really need to do these group studies because we're really interested in more than what happens right after you implement the intervention. So you may be interested in a combination of interventions, or you may be interested in long-term effects. Like, if we're focused on social communication, yeah, it's great if we can get them to tell us their name. But what we're really interested in is, do they make friendships, for example. And to do that, you need to bring together a lot of procedures, and you need to look not just at what happens in the first week or two after you introduce the intervention. Or as another example, which I already alluded to, sometimes you actually have choices, and it'll be difficult from single case studies, not impossible, but difficult to compare those. So we mentioned for acting out behavior or irritable behavior, medications have some evidence behind them, but there are also behavioral interventions. And, how do you pick those, one versus the other? And that probably requires group studies where you actually compare those two approaches. Okay. So, so often these in the autism world, the single case studies get called initial efficacy studies. So they're kind of a start toward demonstrating that a treatment works. And again, sometimes people will say, well, a start is all you need. We don't need to know any more than that. And then other times where people say, well, you also need some group designs. So discrete trials by itself as a teaching method has been viewed as falling in the first category, that the single case studies would be enough to show that you can teach skills with discrete trials, if that's what they actually show. But that if you take a program that involves discrete trials and a whole bunch of other things like we talked about yesterday, like gradually entering the kids into school and involving the parents in the treatment and using some teaching methods other than discrete trials, then you really need one of these studies where you randomly assign to groups or something like that. Okay, so so looking at the initial efficacy studies first, discrete trial training, there was a review that I did, it's getting to be fairly old now, and another review that was published in 2002. The review in 2002 had about 18 different single case studies on discrete trials generally showing success. And one of the handouts that I gave you was a list of studies, single case studies published since then on discrete trials, again showing that, that it's effective in teaching skills. So in terms of the single case studies showing that at least in the short run, you can teach stuff with discrete trials, there are lots and lots of studies from a number of different investigators showing that. And so there are disputes like we were talking about before about whether this is really the right way to go in teaching things like social communication. But there's no question from an evidence-based point of view that you could teach stuff with discrete trials. Okay? And I mentioned, that discrete trials is only one of many ABA procedures. And so there are a bunch of others that also are viewed as having passed this level of evidence. So there are a number of interventions that involve scripts or things like that. So yesterday I mentioned social stories. I mentioned having peers as models, or giving them schedules with a sequence of activities shown in pictures or something. Those are also well studied. Incidental teaching I mentioned is also well studied. And functional communication, which is an intervention for acting out behavior, basically teaching the child to communicate what they want instead of throwing themselves on the floor or whatever, also well established. And then reinforcement procedures for increasing appropriate behavior and decreasing inappropriate behavior, also well established. Okay, so there's a bunch of these, again, not to dwell on the details, but there are a number of ABA teaching methods that are well established in the literature. Now, looking at group studies of sort of intervention packages that use discrete trials, these mainly focus on what is called early intensive ABA. And in early intensive ABA, or it's often called early intensive behavioral intervention, or EIBI, The kids get 20 to 40 hours per week of individual instruction, largely discrete trial training, as we discussed, and it's early in the sense that it begins generally at age 4 or younger and goes for a couple of years from there. So very individualized, labor-intensive approach. So there are a number of different EIBI models, but there's one in particular that's kind of dominant, and that's the UCLA model developed by Ivar Lovas and his colleagues. And that's, I had the good fortune as a graduate student to come up through the ranks there. And so that's, where I've been doing my research. And it's also, as I said, kind of the dominant approach. So yesterday when I presented you phases of treatment and I presented you curriculum maps, those really are based on the Lovas model. And there's certainly other ones out there that, proceed somewhat differently. But I think you could take that one as kind of the standard by which others are, on which others are based, okay? Okay. And so we've already talked about what the treatment involves. So I just want to give you a sense of what the studies look like. And then we'll talk about the studies in aggregate. So the first study, which I won't actually present to you, was published in 1987, and then there was a follow-up in 1993. And that was what really got people excited about EIBI. And what happened in that study is that the kids who got this EIBI made really pretty spectacular gains relative to kids who didn't. So they started treatment at the ages of 2 or 3, and by age 7, their IQs were on average about 30 points higher, which is a lot. And they were also much more likely to be included in general education placements, and they also showed improvements on some other measures. Okay, but that was an initial study by the developer of the intervention, and there were some other methodological things that you might expect with an initial study of that sort. So people started to do replication studies, and Dan, for example, worked with an investigator on one of those that was published in 1998, so eventually a literature grew up around this. But a concern had been that there weren't really any studies where kids were randomly assigned to get EIBI or not. And so the first study in which kids were actually randomly assigned was this one, and that was published in 2000. And so what happened here was there were 28 kids on the autism spectrum. So PDD, NOS is pervasive developmental disorder, not otherwise specified, which is a fancy way of saying autism-like. So they don't qualify for full autism, but they show a lot of autism behaviors. And they were all under 3.5 years old to begin with, and they were all scoring in the range of mild to moderate intellectual disability. And they didn't have other medical problems because, as a bunch of psychologists, we weren't in a good place to treat those kinds of things. Okay? And then what we did was we assigned them, we'd test a bunch of kids, and then we would pair them up. So the top 2 kids in terms of IQ scores would be one pair, next 2 would be the next pair, and so on. And then one member of each pair would go into EIBI, and the other would go into the control group, randomly assigned. So that's called stratified. They're stratified on IQ and then randomly assigned. The intent was to provide 30 hours per week of treatment, but we actually ended up more like 25. And the treatment went for, on average, a little bit more than 2.5 years. And then there was a parent training group where the kids got 5 hours per week of parent training, basically to teach them how to do discrete trials themselves. As parent training goes, this is actually quite a lot of parent training, so they really had a lot of support to learn how to do discrete trials and implement them with their kids. Okay, and then there were a lot of measures. I won't go into them in great detail, but That's how science works. There's lots of measures. And here I'll just show you some of the data. What you see on the left-hand side is their IQ scores when they came into the study, which is when they were 2 or 3 years old. And then on the right-hand side, you see what it was at the end when they were 7 or 8 years old. And so you can see at the beginning, at the 2 to 3 year old time point, they're really scoring pretty much the same. Both groups are right around 50 IQ. But then later, at the end of treatment, the EIBI group is looking substantially higher than the parent training group, and the difference is actually about 16 points. So it's not 30 points, which is what it was in the 1987 study, so that's a big difference. But it is a statistically reliable difference. So IQ was one. There was also a measure of academic achievement where they did better, another on visual spatial skills, and also just inclusion in general education, they did better. They had somewhat higher scores on language, but it wasn't actually statistically significant, so it looked like it was going in the right direction, but it wasn't. We couldn't tell for sure if that was for real. Parents liked us in both groups, but there were also some things that didn't come out. One was just the acting out behavior, and I actually wasn't that concerned about that because the measure we used, which is called the Child Behavior Checklist, probably not a great measure for these kids. There's not a lot of items that get at the kind of behavior problems they present, so we probably should have picked something else. So on the one hand, it's not good news that we didn't see anything there, but on the other hand, it may have just been the wrong measure. But the other one kind of hurt. So the other one is called the Vineland, which is a measure of how they cope with everyday situations, how they function from day to day. And, as we've talked about, that's really something that we're keying on in the treatment. So the fact that we didn't see anything there, that was bad news. So on the one hand, we had some nice effects here. On the other hand, we certainly didn't get everything we were looking for. And we also didn't get the same level of effects that were found in the 1987 study. So there were a handful of studies like that up to 2000. And then in the last few years, starting around 2005, there were a whole bunch of studies. So there were a whole bunch more on the UCLA model. And then there were starting to be a bunch also on other EIBI programs. And altogether now there are 2 randomized studies, the first one that I showed you and one other. And then there are 10 that we would call quasi-experimental studies, meaning that they have an EIBI group and a comparison group, but the groups aren't randomly assigned. So in some studies it's been based on whether there were openings in the EIBI program. So if there were, the families went in. If not, they went to something else. In others, it was actually the family's choice. So the concern there is you usually end up with groups of kids that look pretty much the same. But you wonder, especially about the families, is there something different about the families that choose EIBI? Probably there is. Or even if it's not exactly the family's choice, if there's somehow the families are able to get in when there's an opening, are those the families that are really on the ball? And so on the one hand, this provides some, reasonable test of the intervention. On the other hand, there's some issues with drawing interpretations. The overall problem has been that it's difficult, since we're talking about 2 to 3 years of a child's life, intensive treatment, it's difficult to get families to sign up and let their child's fate be determined by a coin flip or whatever. So there are a lot more of these studies than there are of the randomized trials. Then there are another 10 studies with only an EIBI group. So that you can monitor their progress over time, but you can't really tell how that would compare to kids at the same time and place who didn't get the treatment. Okay. So altogether, there are 22 published studies, and there are a bunch of recent reviews. So I've given you another handout and that's one that should have a staple to it. And it has a table with all but one of these studies. There was one that came out about 1.5 years ago, and I haven't figured out how to squeeze it into the table and still have the table be readable. So I have 21 of the 22 studies in the table, and then I have some other information like citations to those studies and reviews based on that. And then there have also been a bunch of reviews or meta-analyses. Meta-analyses involve taking the statistics from a study and kind of combining those statistics with statistics from other studies. So it's a statistical way of combining results across studies. Okay, so I won't, I'll just show you, there's a bunch of reviews here, and these are also cited in the handout. So I'll spare you going through all of these one by one. That would be tough going. So I'll give you the highlights here. The obvious first question is, does EIBI actually work? So with all of this, you know, acknowledging that a lot of the studies don't use the ideal research design, and you know, as group studies go, some of these are kind of small. So I said, like the medication study had more than 100 kids, and then the randomized trial we just talked about had 28 kids. So again, we've also said that at least, you know, we could teach stuff with discrete trials. Here the question is a little bit different. You know, can we use EIBI to help kids catch up? Okay. And so, drum roll. All right, good. Most people say yes, not everybody. And you'll find if you hang around academics, they never agree on anything. And here I think there are some legitimate disagreements, but some illegitimate ones too. But most reviewers, bottom line, they'll say, yes, it works. So here's the dissenters. So there's still concerns, which I think their dissent represents, that we still need some bigger and better studies in order to really close this out. But again, most people have said yes. But they've also said, you know, we need to get more kids in these treatments, so we need to be clear on things like how much treatment the kids actually got. You know, it's nice to show changes in IQ, but we'd also like to see changes in autistic symptoms or autistic behaviors, or whatever you want to call it. And we'd also like to see more kids in these studies. So again, bottom line, people say yes, but you know, there's still some things we need to do further studies to figure out. Like if we can get more kids, we can be clearer on exactly how big of an effect there is. If we have more measures, we can get a better sense of what it's good for, things like that. Okay, so next question is, if it does work, how big are the effects? So I just said, you know, people would like to see larger studies to really nail this down, but people have taken a stab at it based on the available evidence. And probably the clearest kind of evidence is from these meta-analyses where you statistically combine results across studies. Now, the concern is when you do that, oftentimes it may seem that you're comparing apples and oranges, like people might have used different measures in different studies and then you're putting them all together. But anyway, people have taken a try at doing that, and for IQ, which I mentioned as an outcome measure, one result that was reported a little while ago was a mean effect size for IQ of 0.69. So a question is, what the heck does that mean? So roughly, it refers to what the range of IQ scores look like in kids who've received EIBI versus those who have not. And the finding is that, you know, translated into something resembling English, is that the average child in EIBI has a higher IQ than about 75% of the kids who didn't. Okay? So, you know, not solving all the world's problems, but a significant push. And as behavioral treatment studies go, that's considered to be a pretty good effect. Translated into IQ points, that's roughly something like 8 to 10 IQ points, benefit. Then in another meta-analysis, they looked at the data again. They actually came up with a larger effect size, which roughly corresponds to 86% of the kids in EIBI doing better than the average kids in the comparison group, which would really be quite an impressive effect. And in terms of IQ, that's more like 15, 16 IQ points. Okay. And they also argued that despite the negative finding for adaptive behavior that I talked about, that you could also find effects for adaptive behavior overall, roughly on the order of what we found in the first meta-analysis for IQ. Like 75% of the kids are doing better with adaptive behavior. And another way that people have looked at it is if you look at like individual kids, how many kids show an improvement that couldn't just be due to chance, like their IQ scores changed so much that it was outside what, could have been just a good day or a bad day, okay? And they found that for IQ, about 27% of the kids in EIBI made that kind of change. So there are other kids who made smaller changes, and you couldn't tell whether it was for that particular child anyway, a real change or just, luck of the draw. But for 27%, they concluded that there was no question from a statistical standpoint, or very little likelihood from a statistical standpoint that that was just, a good day, versus about 10% in the comparison groups. And for adaptive behavior, 19% versus 7%. And then another way to look at that is, like, how many kids would you need to treat in order to get one more kid making reliable change than would have happened if you didn't provide treatment. And so they found about 4.5 kids to get one child making reliable change in IQ and about 7 in adaptive behavior. So again, there are other kids making smaller changes, which for that individual might be hard to analyze, but that might be meaningful. But the ones that are quite probably meaningful, those are the percentages they came up with. And again, for behavioral treatments, this is considered to be pretty good. So it's not the be-all and end-all. Obviously, there are a lot of kids who are not benefiting, but it's a pretty good effect. So now another question is, if it does work, why does it work? And that includes things like, amount of treatment. Do they really need that many hours of treatment? Okay. It also includes things like, do they actually need discrete trials? So, we presented a developmental approach. Would that be just as good or even better, for example? And then also the content. So I presented you curriculum maps with specific behavioral targets. Could you, does it really matter what's in those maps, or could you teach some other things and do at least as well? So unfortunately, I'll just whip through this quickly. Unfortunately, we really don't have a whole lot of information on any of these things. So some people have argued that there is evidence that more is better in terms of hours of treatment. But most people, I think, take the position that we really don't know for sure. Some people have also argued that maybe the first year is the most important. But again, other people would say, well, we're not so sure about that. So again, this is an area where we just aren't all that sure. And then when we start getting to other things, we really are not going on very much. So we really have no information on like head-to-head comparisons of discrete trial-based programs to programs that use other ABA methods. Now, another question is, so we already talked about, some of these kids make reliable changes and then other kids don't. And so, who are these kids and why is that, and can we figure out who they are? And all of the studies report that. And just to give you an idea of what it looks like, these are data from that original 1987 study. And what you could see is that when they come in at age 2 or 3, these are IQ scores again. Their scores are all kind of bunched together pretty closely. There's some range here, but they're all, 50, 60 IQs. And then when you look at age 7, and then especially when you look at age 13, there's a huge range all the way from like 30 to 130. And on top of that, it looks like there might actually be 2 groups. There's a group that's, more or less in the average range, and then there's a group that's delayed, and possibly a group in between. Okay. And here's another study. This was the other randomized clinical trial. You again see this kind of bunching together to begin with. There's some differences in scores, but they definitely fan out over time. And it definitely looks like there's 2 groups by year 4. You can also see here, by the way, the kind of data that make people suggest that the first year might be the most important. So if you look at this, a lot of the kids are making a huge jump during the first year of treatment, and there may be a little bit more that happens in the second year, but definitely if you start looking at beyond the second year, things are pretty stable. Unfortunately here, although there's some research, it's still basically something that we don't have very much to go on. There's some evidence that kids who are initially higher functioning tend to do better. So if you look back at this figure here, you can see that the kids who started kind of up here to begin with were kind of more likely to be the ones that made the big gains. But you could also see there's some exceptions, like there's some kids down here who also made some big changes. So there's some tendency here, but it's certainly not a strong one. And things like age and other behaviors that they might present really haven't been shown to be reliable predictors. So we have a study that we're just finishing up now on this, so stay tuned. This one will come out soon. Bottom line is, we can say with some confidence that, not absolute certainty, but pretty good confidence that EIBI, which is based on discrete trial training, is effective in accelerating development. Okay? And so you, as I think, have learned something that actually could help kids. So that's an important, hopefully that's what it's all about. Okay, so that's important to bear in mind. And particularly the UCLA model has been tested pretty well. Now there may be some advantages for kids who get intensive treatment and who get especially intensive treatment. And so as this plays out as a practical matter, what often happens if you're sitting in an IEP meeting or any sort of treatment planning situation, the tendency might actually be to give the most intensive treatment to the lower functioning kids, like they're the kids who have the most needs, and so you ought to focus on them. And it's a tough argument to make that actually we might be better off focusing, here at least kids who show some skills coming in, like they have some language skills or they can get some things right on an IQ test, that those might be the kids who show some ability to learn. But that's, in general, what the evidence would suggest here, that these might be our best candidates for the treatment. Okay. And unfortunately, a lot of other things about, do you really need to use discrete trials, or could you use some other teaching method? All we can say is we have good evidence that discrete trials work, and that discrete trial-based programs seem to have some good long-term effects. So, I think, again, if you're sitting in an IEP meeting or treatment planning meeting, you could say, yeah, that's an interesting academic question, but it's not relevant to planning treatment for this kid. And then I still want to emphasize too, so we know some things I think we can say with great confidence that we can teach individual skills with discrete trials. You know, we have the 18 studies in the 2002 review. We have the 12 or so studies on the sheet I gave you in the handout. You know, I don't think there's any reasonable doubt that you can teach things. And I think, you know, looking across the 22 studies, we can, you know, have some doubt, but we could still feel a pretty high degree of confidence that we can get long-term effects. But that said, there's still a lot of things that we identified that we don't know. You know, we'd like to have larger studies so we could really pin down how big the effects are, in what areas the effects occur, and you know, exactly what goes into an effective treatment program. But I think, again, the bottom line for you who will go out and practice this is it's an effective tool, you know, for early intervention for many kids, perhaps especially the ones who come in with already having some skills. One other thing I want to mention in that regard, and that'll be my last comment, is that because of this, you often have kids continuing in what are essentially EIBI programs after they're no longer in early intervention or preschool. So we routinely see 12 and 14-year-old kids who are still getting home-based discrete trial programs. So nothing that I've talked about here or anything I talked about yesterday justifies doing that. There's no evidence that it makes sense to do that for these kids. And in fact, I think there was an excellent question about that, one question about a sixth grader and one about an adult. You can still use discrete trials to teach specific skills, but that's really in support of other things that the child is doing. It's not something that's the main activity for the child, you know, beyond these preschool years. You know, this is early intervention to help them catch up when you're using intensive discrete trials. And then after that, it's kind of what you use as a way to teach stuff when you really can't teach them in a classroom or any other kind of situation. Okay? So that's it, and thank you.